So, in the last video, we finished off gout and other diseases that can present very similarly to gout. So we saw septic arthritis, gout, pseudo-gout, which is now called calcium pyrophosphate deposition disease, and we did a couple practice questions which made it very clear to see what the main differences between the three differentials usually will be. We also saw systemic juvenile idiopathic arthritis, which can be a very confusing question because it might not be something you'll be expecting. And we discussed Sjogren's syndrome, where you're just completely dry, right? So you have antibodies against your lacrimal and salivary glands and many other exocrine glands as well. So there was a lot of stuff in that as well, and that was pretty much one of our first autoimmune set of diseases that get discussed in musculoskeletal. Now, on the rest of this chapter is pretty much the seronegative spondyloarthritis, right? All the different arthropathies that they're going to be. You have your lupus, which is a really big thing, antiphospholipid syndrome, PMR, fibromyalgia, right? A bunch of these guys that all have some level of either autoimmunity associated with it or something physical that's associated with it. And these questions often tend to be each other's differentials, right? So you have to be able to identify like what exactly sets them apart from each other. So first thing we'll be starting with seronegative spondyloarthritis. So arthritis without rheumatoid factor. So there's no anti-IgG antibodies here at all. No rheumatoid factor. And of course rheumatoid arthritis itself had the anti-citrullonated peptides over there. So that was a whole different thing for itself. Strong association with the HLA-B27, which is an MAC class 1 serotype. Remember from immunology, to identify between MAC1 and MAC2 was the number of letters. So this only has one letter here, only a B, so it's a MAC class 1, whereas something like HLA-DQ, DQ has 2 letters, that would be an MAC class 2 serotype. The subtypes, which are these 4 diseases, known usually by just being called the pair diseases, share variable occurrence of inflammatory back pain, peripheral arthritis, enthesitis, and dactylitis, as well as uveitis. Now, uveitis is a pretty interesting topic. They often love to throw uveitis at various questions, or even sometimes start with uveitis and then just try to lead you into a confusing way. So be ready for that. Subtypes share, so you can see the back pain associated with morning stiffness and improves with exercise. This should remind you of osteoarthritis. Rheumatoid arthritis, right? Rheumatoid arthritis is the one that when you wake up in the morning, everything hurts a lot. And then as you start moving, things get better. Whereas osteoarthritis, that's the one associated with feeling worse the more you use it, because osteoarthritis is due to wear and tear. So you wake up in the morning feeling pretty decent. The enthesitis, which itself is just inflamed insertion sites of tendons, right? So that's going to be pretty painful, pretty debilitating. You won't really be able to move much. And these are usually in the question, so you really have to be ready. Now, oftentimes when they throw in this fact, right, associated with morning stiffness, improve with exercise, you don't immediately want to think of rheumatoid arthritis. You want to look for other things that are also seen in rheumatoid arthritis. We talked about all the differentials in one of the earlier videos between rheumatoid and ulcerative colitis. Rheumatoid. I'm getting a phone call. Alright, anyway. Between rheumatoid arthritis and osteoarthritis, so those differentials should really help you. But when you see rheumatoid type of stuff happening, make sure you look for other things too. Search for other details that can help you actually lock in rheumatoid arthritis, because it might not be rheumatoid, it might be one of these things over here. So the first thing we have is psoriatic arthritis. This is associated with skin psoriasis and nail lesions. You'll have asymmetric and patchy involvement of the skin, dactylitis, and pencil and cup deformity of the DIP on X-ray. Right, so remember, whether your distal interphalangeal joint was involved or not was a really big deal. Right, you have your DIP, which is the very distal one. You have your PIP, which is the more proximal one, and then the MCP. The PIP was involved in pretty much both osteo and rheumatoid arthritis, but the distal was only involved in osteoarthritis, right? So if you're seeing some kind of mixture, as you could see here, right, you could see a patient that might present with morning stiffness, which is a rheumatoid arthritis thing, but then involvement of the DIP, which is an osteoarthritis thing. If you see both things, then you want to start searching, okay, does the patient also have psoriasis? Because then it might just be psoriatic arthritis, right? So that's the kind of connection you want to be able to make so you can actually know how to search for a diagnosis, right? Part of being a doctor isn't just about knowing the diagnosis based off of some things, but also being able to find the diagnosis. You should be able to hunt for the diagnosis, which involves knowing what screening tests you want to order, knowing what you're looking for in the patient on physical exam, right? So, and the MCP, the metacarpophalangeal stuff, this stuff was always involved in rheumatoid arthritis. So anyway, here they're telling you you're going to see a pencil and cup deformity. It's really hard to actually know what they're talking about. There's a interesting imagination involved, I guess you could say. If you search more online on Google for pencil and cup x-rays, you'll pretty much see the same thing. It's not really exactly clear what they're talking about when they say pencil and cup. Let me show you some more pictures. Because the pencil and cup, whoever makes up these names is just using a very interesting imagination there. But I'm not exactly sure what they're talking about when they say pencil and cup deformity. Psoriatic arthritis, there you go. Alright, so pencil and cup deformity of the DIP. I'm not exactly sure. You can see, like right here, there's a problem with this patient in the DIP. That x-ray is very clear. There's a problem there. Again, I can't really see a pencil and cup that they're talking about, but there's apparently a pencil and some cup. Okay. So main thing is you can see always when you look at x-rays, you want to make sure you look at each finger and the carpal bones over here. Make sure they all look normal and no one's like shifted out of place or cracked. And clearly this is cracked right here. That's your DIP. So when you see something like that, you start figuring out this must be involved with your psoriatic arthritis. It's not exactly a keyword, so it's not something that'll pop up and give away the answer to you, but it can help. Ankylosing spondylitis is the next thing. There's symmetric involvement this time of spine and sacroiliac joints. So psoriatic arthritis had the asymmetric involvement of the skin, right, and the bones. Right? So you're going to see psoriasis that isn't exactly symmetric. Your bone involvement and the nail lesions are all going to be asymmetric here because it just is like that, right? Whereas rheumatoid arthritis was very symmetric. It's going to be both sides equally. Osteoarthritis was asymmetric. It's always good to go back and kind of revise little topics like that, especially with OA versus RA and Crohn versus UC, because those differences between the two are very critical. So you start seeing that. You see ankylosis, which is joint fusion, again the uveitis, and aortic regurgitation, which is a pretty high-yield topic, right? Aortic regurgitation itself is a very high-yield topic, and what NBME likes to do is it loves picking on facts like that, right? So they'll give you a question, and you'll be reading it, and they'll tell you enough information so you'll know exactly the fact that it is HLA-B27. You might even exactly know it's ankylosing spondylitis, and they'll be like, what heart murmur do you expect to hear? And that just hits you out of nowhere on NBME, so be ready for that. You're going to hear an aortic regurgitation in patients with ankylosing spondylitis. For whatever reason it occurs, just know it. Just try your best to remember that. But the more defining feature is the ankylosis, right? Because it's named like that too. So you get joint fusion, and there's bamboo spine, and a lot of other joints start fusing, and your bones are not supposed to be fusing. Costovertebral and costosternal ankylosis may cause restrictive lung disease, and respiratory is a big deal. Monitor degree of reduced chest wall expansion to assess disease severity, more common in males. And they had a question about this on UWorld, right? So UWorld said, 34-year-old man comes to the office for progressive low back pain for many years. Extremely high-yield topic, low back pain. He reports stiffness and pain are worse in the morning but improves throughout the day, and ibuprofen gives some relief. Labs show HLA-B27 antigen, which gives away the fact that this must be ankylosing spondylitis. What should you monitor for disease progression? And that's supposed to ring a bell because you read it, right? Disease progression or disease severity, and monitor. Right, so you're going to monitor chest wall expansion, right? So degree of chest expansion was the answer there. Right, so you have to remember the words you read for it to ring a bell. You don't have to remember it flawlessly, but I've repeatedly told students, and I always talk about it, one way to remember what you read is to review it in your mind without the book in front. So, like, for example, let's say you're studying with me right now. Later on, you might be cooking, walking somewhere, going for groceries, whatever you're doing. In your mind, think about what you read. and reiterate what you read. It helps a lot. You'll be surprised. So if you're sitting there, you're like, all right, what was the stuff I studied today? So yeah, pear diseases, uveitis, psoriatic arthritis had the penicillin cup, ankylosing spondylitis had the bamboo spine, and aortic regurgitation. Everything is fusing. I got to make sure the person can breathe, so I should check for chest wall expansion. These are the thoughts you should have in your mind as you're reviewing this topic, because you studied it with me, or you studied it on your own. And when you start having thoughts like that, and you can actually review topics without the book in front of you, it sticks to you. It becomes very significant at that point. One more topic here is the inflammatory bowel disease, which I just said. Knowing the difference between Crohn and UC, and then being able to differentiate both of those from other colon problems is significant for step 1. It's a very high-yield topic. And seronegative spondyloarthritis patients will usually have one or the other inflammatory bowel disease. They'll have one or the other. It's very common. The last thing here is something we talked about a lot when we were in microbiology, which is the reactive arthritis. In sketchy micro images, the reactive arthritis is always depicted by a man or woman, any character that's laughing and smacking their knee. Like they're laughing so hard. It's a common thing people do, right? So you're laughing so hard, you just smack your knee really hard and you keep laughing. That's the reactive arthritis. They're talking about reacting by hitting your knee. That's why it's arthritis. And it's very common with patients who have Campylobacter history, chlamydia history. Right? Those are two I've definitely seen a lot of questions on. But yeah, Shigella, Yersinia, and Salmonella are also involved. So this was formerly known as Reiter syndrome. It has a classic triad of conjunctivitis, urethritis, and arthritis. And being that it's one of the pear diseases, it has association with HLA-B27, which means it can present with any of these other things as well. Right? So don't forget that reactive arthritis could have the back pain, the peripheral arthritis, enthesitis, all of these other things. And it can have one of these other guys. Right? So don't let those other little things throw you off. Right? What makes pear diseases such a good thing is here you literally have a pair of diseases that can overlap. And your question might just be about reactive arthritis, but they might throw in something about ankylosing spondylitis. Maybe the patient is having trouble breathing, and they don't talk about anything else. They just say he has trouble breathing too. That's just there to throw you off. Pick out, always pick and choose. Pick and choose the details that you actually care about. Okay, because that's a very common thing. You're going to get real life patients that are going to come in, and you'll be like, how can I help you today? They're going to give you their life story, but you don't care about their life story. You only care about the things that are relevant for the disease or whatever main issue they told the nurse that they're here for, right? And that's on your paper. It's on your paper. The patient is coming because maybe he's been having chest pain. Right now, if he's talking about his daughter and shit like that, you don't care. Right? So that's what you want to make sure you're able to do when you're reading step 1 questions. This is a little note. Skin findings include keratoderma blenuragicum, which is hyperkeratotic vesicles on the palms and soles, and something called Seronegative balanitis, which is serpiginous annular dermatitis of the glans penis. And these things can really throw you off, all right? Really throw you off. But that was something I got from a UWorld question where they mentioned both of those things to help you figure out reactive arthritis. But we don't really think of many diseases when we think of things that can cause something on your palms and soles, right? There was only a Coxsackie A, rickettsia, and one other thing. I can't remember the whole Cars mnemonic. So there aren't that many things to think of in the first place, and those guys weren't even related to reactive arthritis. And when you think of Seronegative balanitis, which is a word I've never really seen anywhere else besides that note and the URL question, dermatitis of the glans penis, very few things actually cause that. So all of that is reactive arthritis related, and you really want to make sure you're ready for that. They show you here the bamboo spine stuff, and then at the bottom here I have a couple questions. But before I do that, it's going to bother me if I can't remember what that Cars mnemonic was. So let's take a look at that real quick. Where did they talk about it? At the end when they discuss rickettsia. Yeah, right here. Okay. So it was, what was it? Oh, syphilis. Okay, all right. Coxsackie A, Rocky, mountain spotty fever, which is the rickettsia, and the S was for secondary syphilis. Gotcha. Okay, so let's take a look at some of these questions now related to either the pear diseases we just looked at or something that's coming up, which is lupus and whatnot. So first few are UWorld, and the last one here is AMBOSS. First question says, 35-year-old man comes to the clinic with acute right knee pain and swelling. Patient is able to bear weight but has significant pain when climbing stairs or walking for extended distances. Ibuprofen provided only temporary relief. He was seen by his PCP for a diarrheal illness 2 weeks before onset of the current symptoms. Cultures of a joint aspirate reveal no bacteria. What is most likely associated with his joint symptoms? Okay, and this had to be a pear disease, and it was HLA-B27. So let's take a look at the question and really try to make sure we catch what it was, right? Because you could finish reading the question and have no idea that it was B27. He's 35. He has acute right knee pain and swelling. All right. So now remember, we just in the last video did the gout, pseudo gout, and the septic arthritis, and we want to think, is it one of those things? Since it's knee involvement, it could be the pseudo gout, which is calcium pyrophosphate deposition disease, or it could be he's young enough to be having sex, so it could be someone with septic arthritis. He's able to bear weight. Now, when we did the calcium pyrophosphate deposition stuff, they were able to bear weight, but the septic arthritis people, they were in immense pain, right? They were not able to bear pain. And this question does both things. They tell you he can bear weight, but he has a lot of pain when he's climbing stairs or walking extended distances. So it doesn't really look like septic arthritis, but still we have to rule it out. We haven't ruled it out yet. Ibuprofen provides temporary relief. They don't give you his temperature, so you don't know if he has fever. He saw his PCP for a diarrheal illness 2 weeks ago, so that's a huge deal. You know, a 35-year-old man in America, what could possibly cause diarrhea in them? Cultures of the joint aspirate reveal no bacteria, so it's not septic arthritis. The diarrheal illness is supposed to then ring a bell for you, and every time you think of a man with diarrheal illness, a history of something like that, and now presenting with right knee pain, you want to think of reactive arthritis, where the guy is laughing or reacting to something funny and smacking his knee. Right? Reactive arthritis was a main picture for Campylobacter. There was a really good picture for Campylobacter jejuni. So let me go back and show you that. Let me see. Yeah. See jejuni. Right here. Right. So this picture right here. This is a man for Campylobacter jejuni. You see how he's doing this action right here? He's reacting to all the bears playing around and smacking his knee. That's reactive arthritis, and they're all sitting on red stools, which is a sign of bloody diarrhea, which is most likely what that patient had. Right, so really important to remember, this is the #1 cause of acute gastroenteritis in children and adults in America, industrialized countries. Okay, so when I said what could possibly have had caused diarrhea in that 35-year-old man, in your mind the immediate answer should have been C. jejuni. You need to be able to associate all of these microbiological diseases with specific populations, right? The meningitis, diarrhea, UTIs, you need to be able to associate the #1 bacteria or bug involved or virus involved with the #1 group of people involved. Who does it actually affect? That's how you actually master microbiology. And then here they're connecting it to a pear disease, right? So it's clearly reactive arthritis and not anything else. Next question, 25-year-old woman comes to the physician with arthralgias in her hands for the last several months. The pain frequently involves her wrists and proximal finger joints bilaterally. Okay, so arthralgias, last several months, so it's pretty chronic. It involves the wrists and proximal finger, so proximal is more PIP, and bilaterally, so it's sounding a lot like rheumatoid so far. It is worse in her wrists sometimes and her hands at other times. Now, that is migratory arthritis, right? It's moving. It's in one place and then it's another place sometimes. The patient has no other medical problems or medications. Her CBC has 3.2 million red blood cells, which is low, 90,000 platelets, which is also low. It's supposed to be 150 to 400, and 2,300 leukocytes, which again is also low. Right, so all of these are low. Further evaluation reveals proteinuria and red blood cell counts. Now, at that point, when they tell you that there's renal problems in this woman too, that was a huge giveaway for lupus. All right, we have the arthritis already. We're thinking rheumatoid. Then they give you a CBC that doesn't look normal. Then they also tell you that she has renal problems. this is extremely systemic, right? It's everything. She has arthritis, anemia, thrombocytopenia, leukopenia, and proteinuria and red blood cell count. So that's nephritis right there, nephritic syndrome. That's systemic lupus right there, right? Everything is affected in lupus. Antibodies against blood cell autoantigens, which is a type 2 hypersensitivity, leads to hematologic abnormalities and immune complex deposits, which is the type 3 hypersensitivity part, all leading to lupus nephritis, diffuse proliferative nephritis. When you get to renal, you'll see which type of renal damages are associated with which kind of diseases. And diffuse proliferative is also known as wire looping. There's going to be wire looping there, and that's how you remember lupus nephritis. Those are all key words for the type of nephritis you get in a lupus patient. Okay, the patient will have spherocytosis and a positive direct Coombs test because there are antibodies and antigens, and the Coombs test is going to be positive. Antibodies against the platelets are what's going to cause the idiopathic thrombocytopenic purpura, right? You just make antibodies against the platelets for no reason whatsoever, but there's nothing actually, causing her to lose her platelets. She's just killing them off. She has lupus, right? Classic question, very classic question for lupus. 30-year-old woman comes to the office due to a facial rash for the past 3 weeks. The rash worsens with sun exposure. She also reports easy fatigability and occasional pain and swelling of her hand joints. Again, we're seeing a rash that's photosensitive, fatigability, which rings a bell for anemia, pain and swelling in her hands and joints, all sounding a lot like lupus again, right? Past medical history is notable for mild cervical dysplasia that was diagnosed at age 21 and resolved spontaneously. She doesn't smoke or drink, blood pressure is a little high, physical exam reveals mucosal pallor, superficial ulcer on the hard palate, and a rash similar to image A of the lupus stuff, but on an older woman, and it's pinker, right? Because remember, these pictures are not always going to be like this on your step 1. So you have to make sure you look at many other variations of lupus rash. Then they go on to say cardiopulmonary and abdominal exam are normal. What lab finding is most likely to be seen in her condition? And since this is a URL question, they gave you everything. They gave you everything you needed to be able to diagnose the patient has lupus. And what would you see? You're going to see on lab findings, you're going to see decreased levels of complement, right? Because you have the type 3 hypersensitivity part, you use up all your complement, you deposit the complement in your kidney, leading to nephritis. She has lupus, and the photo in the question has a photosensitive butterfly rash associated with inflammatory arthritis. Autoantibody binding to self-antigen leads to the formation of circulating immune complexes that deposit in various organs and cause complement activation, leading to reduced serum complement levels. Okay, so those are the URL questions. 2 of them were lupus. 1 was a really simple question on paired diseases, reactive arthritis. This one down here at the bottom, that is an AMBOSS question related to the same topic as well. So it says an autopsy of a patient heart who recently died in a motor vehicle accident shows multiple nodules near the line of closure on the ventricular side of the mitral valve leaflet. So under the leaflet. Okay. Microscopic exam shows that these nodules are composed of immune complexes, some white blood cells, and thrombi. So there's no bugs, right? There's no microbiology involved here, and that's a very big giveaway to what the diagnosis is here. These nodules are most likely to be found in which kind of patient? And then the correct answer was a 41-year-old female with a facial rash and non-erosive arthritis. A facial rash and symmetric non-erosive polyarthritis in a middle-aged female is highly suspicious for lupus. Systemic lupus, remember SLE has LSE, Liebman-Sachs endocarditis. When we were in cardiovascular, we saw LSE and SLE. That's the thing you have to remember. Liebman-Sachs endocarditis is a thing like this where you find immune complexes and white blood cells and all this other shit. Anything but a bacteria or a virus or anything like that. You're not going to find anything like that at all. No bacteria, no bugs, on a heart valve. If you find only autoimmune things on a heart valve causing damage, that is a sign for Lipman-Sachs endocarditis, which is most frequently related to lupus. And that's what this patient has, right? It's a deposition of immune complexes and platelet thrombi on either side of valve leaflets in what is known as Lipman-Sachs endocarditis. Although the vegetation seen in LSE are usually asymptomatic, they are easily dislodged and can embolize, causing complications, right? It can cause a stroke, it can cause, what do you call it? A stroke would be if it goes to the brain, but it can cause a clot anywhere else as well if it goes into your other limbs. So all of that is going to be problematic, and you can review that. You can go back to cardiovascular, take a look at cardiovascular Lipman-Sachs endocarditis information and see what that looks like. Now, here were some of the other answer choices that actually got picked out pretty frequently by most of these people who most likely didn't identify that this is Lipman-Sachs endocarditis. Another answer choice was, maybe you would see something like this in a 54-year-old male who recently underwent dental surgery. But when you see this in a UWorld question, or step 1 question, of course, a 54-year-old male, anyone going under dental surgery, that is supposed to remind you of viridins. So if someone undergoes dental surgery, you always think of viridins, bacteremia, and that didn't make sense here because there were no bacteria. Right? There were no bacteria at all. A 71-year-old male with acute onset high fever and nail bed hemorrhages. The high fever and nail bed hemorrhages would again be seen in something bacterial. That would be bacterial endocarditis. And the last one here, a 6-year-old female with subcutaneous nodules and erythema marginatum. A lot of students actually ended up picking this choice too. But again, subcutaneous nodules and erythema marginatum are actually manifestations of acute rheumatic fever, another cardiovascular topic, which results from the formation of autoantibodies after untreated group A streptococcus tonsillopharyngitis. Unlike the isolated endocarditis found on autopsy here, the nonspecific carditis seen in acute rheumatic fever tends to involve the pericardium, epicardium, myocardium, and endocardium, with the mimicry with the M protein, right? So it's really important to make sure you're able to associate each one of these 4 different patient types with a very specific disease or condition or presentation, right? Each of these histories is related to a whole different patient. Now on the next page, we finally start looking at systemic lupus erythematosus. So what's happening here? At the top they tell you systemic, remitting, and relapsing autoimmune disease. So there might be periods in this patient's life where everything was okay. Organ damage primarily due to a type 3 hypersensitivity reaction and to a lesser degree a type 2 hypersensitivity reaction. And I just broke that down for you guys when we talked about the explanation for, where did I see it? Yeah, right here. See, in this first lupus question right here with 25-year-old female, right? Antibodies against blood cell autoantigens is an antibody and an antigen. That's type 2. And then the complex deposits, which also has complement, that's 3 things. That's a type 3 hypersensitivity. Majority of the organ damage is due to the complement deposition. So that's type 3. But the direct anemia and the killing of platelets, right? Antibodies against platelets, those things are type 2, where an antibody is just killing an antigen. So both things are involved in SLE. Associated with deficiency of early complement proteins, C1q, C4, C2, leading to a decreased clearance of immune complexes. Now, this part is actually really important because knowing complement deficiency is something that you already revised when you did your immunology principle. Right? Always go through principles first. And let me see, immune responses, okay. They discussed with you right here what happens with early complement deficiencies and what happens with terminal complement deficiency. And this is always like a giveaway question on step 1, right? If someone has recurrent Neisseria bacteremia, that's a patient who probably missing terminal complement. Early complement deficiency, increased risk of severe recurrent pyogenic sinus and respiratory tract infections, increased risk of lupus. It's also true the other way around. Lupus patients just have early complement deficiency. And when you have early complement deficiency, you're going to see these things. So you have to remember that, right? You're missing your early guys over here, and you can't eventually lead to making MAC. You won't be able to do the latter stuff either very well, at least, right? Because you need C3b to be able to do this stuff and then go there. However, the later part can also activate itself with C5 directly. C5 can start up its own thing from here. But you need this part for your recurrent pyogenic and respiratory tract infections. So that can be a presentation. That's something you're expecting in a patient with lupus. And then classic presentation is going to be rash, joint pain, and fever in a female of reproductive age, especially of African American or Hispanic descent. Or also, more importantly, the joint pain is migratory. It is a migratory arthritis in lupus, right? So sometimes the wrist, sometimes other parts, and it's never constantly the same body part. So the first thing they tell you is the LSE and SLE thing I was talking about, right? Liebman-Sachs endocarditis. It's a non-bacterial verrucous thrombi, usually on mitral or aortic valve, basically the left heart, and can be present on either surface of the valve, but usually on the undersurface, okay? Like we saw in the question we just did. Lupus nephritis is glomerular deposition of DNA and anti-DNA immune complexes. Can be nephritic or nephrotic, causing hematuria or proteinuria respectively. Most common and severe type is diffuse proliferative, and that's something we'll see later on when we do the renal section. Common causes of death in lupus are renal disease, which is the most common, infection, and cardiovascular disease due to accelerated coronary artery disease. So if you have a lupus patient, you need to make sure that their cholesterol is managed well, they're on statins, they're eating well, and they're trying to do as much exercise as possible. And that's specifically difficult because they have arthritis, so they can't really do much exercise. They also have the tendency to develop photosensitive rashes, so they can't run in the sun. And so a lot of things are working against them, and management is much more than just telling them what medication to take and sending them home. In an anti-SSA positive pregnant woman, there's an increased risk of newborn developing neonatal lupus, leading to congenital heart block, periorbital diffuse rash, transaminitis, and cytopenias at birth. So this SSA stuff was something that we discussed in the last video when we talked about Sjogren's syndrome, right? In Sjogren's syndrome, you specifically have SSA and SSB, right? The Rho and La antibodies. Those are pretty unique to Sjogren. You can find it in other places too, but those usually, when you see a Rho or La, you want to think of Sjogren's syndrome. And they tell you here too that anti-SSA and anti-SSB may also be seen in lupus. So now that we're finally in lupus, they're telling you that if you have a pregnant woman who has anti-SSA, which is the Rho, it's an antibody against ribonucleoprotein. You have to remember that too, right? Both of those are anti-ribonucleoprotein antibodies, right? RNP. So if you have a pregnant woman with anti-SSA, her newborn, her infant might be born with neonatal lupus, which pretty much would lead to death. Congenital heart block, periorbital diffuse rash, transaminitis, and cytopenia, all of which is just terrible for a baby. So what are the things you look for in lupus patients? Definitely the rash, either malar or discoid, and they're showing it in two different places, but the discoid rash can also occur on the face. Okay, so they're showing you discoid rash on the fingers here, malar rash on the face. Step one is really shying away from showing you a good butterfly rash. They don't show you the really pretty butterfly rash. They'll try to show you something that looks really weird. And you have to remember, it doesn't matter how the rash looks. There's no perfect design to it. If it's on the face and it's photosensitive, you start thinking lupus and you move on and try to find other things. Non-erosive arthritis. So this is really significant, right? They use this word a lot. Non-erosive. So the arthritis isn't actually breaking bone. It's not breaking bone, it's just painful. And there's a lot of inflammation, but it's not erosive. Serositis, like pleuritis, pericarditis, they can have the pericarditis with the friction rub and all that. Hematologic disorders, anemia, cytopenia, whatever, it's usually going to be pancytopenia, but cytopenia. Oral or nasopharyngeal ulcers, usually painless, but they might describe it as painful because it might hurt them. Renal disease, notably the diffuse proliferative nephritis. Photosensitivity, which goes with rash. Anti-nuclear antibodies, anti-double-stranded DNA antibodies, anti-Smith antibodies, anti-phospholipid antibodies. There's a bunch of antibodies involved. And these antibodies are always going to be confusing because lupus itself is the great imitator. So it shares antibodies with many other diseases, and you can't specifically, pinpoint that this patient has lupus just based off of antibodies. It's really hard. The last thing on this same section they also talk about is mixed connective tissue disease, which previously first aid used to talk about under under biochemistry. They would talk about this at the same place where they talk about splicing of RNA, and now they moved it out of there and they only talk about here. So this disease, mixed connective tissue disease, also has features of lupus, as well as systemic sclerosis and or polymyositis, right? It has features of all three. So again, it is mixed, and it's also a very good imitator of multiple diseases. It's associated with anti-U1 ribonucleoprotein antibodies. So what is that? What are we talking about when we say anti-U1 ribonucleoprotein? So let's take a look at that, because they should not have entirely moved it away from here. They should have kept it here. They could have talked about it in both places, but they didn't. So right here you have splicing of pre-mRNA, right? And you can see that there's the green guys. Those are the guys that are going to pretty much orchestrate the whole splicing stuff. So you can see right here, the first one is the U1 small nuclear ribonucleoprotein, and the other one is your U2. You're actually going to be attacking this guy in mixed connective tissue disease. And if you mess up splicing, you mess up the production of many different proteins, which really will be problematic. Right, so that's something you want to keep in mind. And also keep in mind where splicing occurs, right? The GU and the AG. This is something that questions have been picking on lately because it can look so intimidating if they give you something like, this. They give you something like this, and then they tell you that you change this G to something else, or you change that G to something else. If a G is being changed to something else, a lot of things are going to get messed up, because you have to see that's exactly how you removed it, right? This GU and this AG was exactly how it was kind of able to determine where to remove the whole splice area, and those alterations are pretty critical. But yeah, anti-U1 antibodies are hitting this right here. So that's your mixed connective tissue disease. Let's take a look at this question right here. So this one says, it's from Ambos. It says, a 32-year-old woman comes to the physician because of fatigue and joint pain for the past 4 months. Examination shows erythema with scaling on both cheeks that spares the nasolabial folds and 2 1-centimeter lesions, ulcers in the oral cavity. Further evaluation of this patient is going to show what? Well, it's going to show everything a lupus patient has. She's going to have decreased lymphocyte count according to this question. This patient has lupus with symptoms of arthralgia, mild rash, and oral ulcers in a young female. In fact, you should understand that for NBME, remember, NBME questions don't give you a lot of information. So if you get a question where they tell you that a woman is presenting with an oral ulcer, you can right ahead just understand it's lupus. There aren't that many diseases that can cause an oral ulcer in a female. Very few things that can actually cause that. I, for one, right now, can't actually think of anything else. So, the only nasopharyngeal ulcer thing that I know of other than this is the nasopharyngeal carcinoma that you can get in Asian people from Epstein-Barr virus. Other than that, nothing else really causes oral and nasopharyngeal ulcers in young females. So if you see that alone is almost pathognomonic for lupus, right? And that's what they gave you here. That's pretty much all they gave you here, but they gave you a lot more. This one word fatigue is a huge giveaway, right? When someone presents with fatigue, immediately the first thing you think of is anemia, and she probably has that too. Okay? So that's it. Oh, and they gave you the rash. They gave you the rash, the butterfly rash description, which, again, too much information, right? These questions give you too much information, and it makes it really easy for you to figure out what the patient has. So don't be used to that. Don't be used to that if you're preparing for an NBME exam. Do not be used to that, because you're not going to get everything. But, still use this study, because you should understand that if some of these things are all presenting together, then you read another question where they didn't tell you the oral ulcer or they didn't tell you the rash, it should still come to your mind. When you read half the story, you should understand the rest of the story too, just because it's all associated together. All right? So that's lupus. The other half of this page discusses antiphospholipid syndrome and polymyalgia rheumatica. This one we talked about a lot in cardiovascular. But let's look at this one up here first. So antiphospholipid syndrome. This is something that should ring a bell for you anytime you get a question about a woman with recurrent abortions, recurrent automatic or autonomous abortions. Primary or secondary autoimmune disorder, most commonly in lupus. Right? So it can be secondary to lupus. Excuse me. So this is diagnosed based on clinical criteria including history of thrombosis or spontaneous abortion, along with lab findings of lupus anticoagulant, anticardiolipin, and anti-beta-2 glycoprotein 1 antibodies. Again, we see a bunch of these antibodies. Some of these are seen in other diseases as well. In fact, the anticardiolipin stuff we talked about in microbiology, because this is what causes a false positive in syphilis tests. Okay. So they talk about that here. They say anticardiolipin antibodies can cause false positive VDRL and RPR, in both of which are tests that you do for syphilis. And lupus anticoagulant can cause prolonged PTT that is not corrected by the addition of normal platelet-free plasma. Right. So remember that PTT was your HTTP stuff, so that's the heparin-related stuff. And in these patients, if you give them platelet-free plasma, the PTT should correct, if the issue is simply that they're missing some factors. If the issue is not simply that they're missing some factors, then you know that there's something else messing it up. And here is the anticoagulant they have. Right? They have lupus anticoagulant, which is acting like heparin. And that lupus anticoagulant in a patient who's trying to get pregnant is going to be really problematic. So she keeps getting spontaneous abortions. Treat this with systemic anticoagulation, and that's generally all you can do. Here I have some notes from UROS. This one says the anti-beta-2 glycoprotein antibodies, which is right here, are anti-apolipoprotein H antibodies. The same thing. They're both two different names for the same exact thing. Right, so this beta-2 glycoprotein is also apolipoprotein H. They inactivate proteins C and S as well as antithrombin 3, which now you have to think about things we talked about in HEMONC with the coagulation cascade, resulting in hypercoagulability. Remember that proteins C and S cut and stop. Hold on, give me a second. YouTube पे क्या हुआ? ठीक. Always got to pick up mom's phone call, right? Can't do anything about that one. What is it? Oh, yeah. Okay, so this anti-beta-2 glycoprotein, this antibody against all of that makes it really hard because you inactivate proteins C and S, right? Now, if you have these antibodies stopping that and you inactivate protein C and S, or protein C and S, they're supposed to stand for cutting and stopping coagulation, right? And they also activate platelets and vascular endothelium. So this is all going to be really problematic. You have to treat this with aspirin to inhibit platelet activation and or warfarin as an anticoagulant to maintain INR between 2 and 3. But it's not given to patients who had no thrombotic symptoms. In pregnancy, remember from HEMONC that it's best to use low molecular weight heparin and low dose aspirin. In refractory cases, you might have to do plasmapheresis. Okay, so this is just a little bit extra information on a disease that is usually easy presentation. It's usually pretty easy to catch, usually not the most confusing topic, and almost always going to be a female patient. In fact, most of these autoimmune diseases, as you can tell, are related to female patients, right? We're seeing female hands here with the pear diseases. This is also a female patient for Sjogren's syndrome. Most times it can happen to a male too. Lupus, of course, can happen in both genders, but usually female, right? They tell you female of reproductive age. And then PMR now, this last one down here, is also most commonly seen in females. And we talked about it when we did cardiovascular. So you see pain and stiffness in the proximal muscles, mostly shoulders and hips, often with fever, malaise, weight loss. Does not cause muscular weakness though. More common in women over age 50 and is associated with giant cell temporal arteritis, which we saw in cardiovascular pathology. So you're going to have signs of increased inflammation. ESR and CRP are going to be high, but your CK is normal because there's no muscle breakdown. There's no rhabdomyolysis happening. And you need to give these people low-dose corticosteroids. All right. Now, because it's entirely related to temporal arteritis, if there's a high chance that you think they have temporal arteritis, you need to get them started on the corticosteroids way before you even try ordering a biopsy because they might go blind with the temporal arteritis. So let's go back and take a look at temporal arthritis to do a quick refresher of that. And that's another thing you can go back and look at after this video if you're studying with the playlist and you're trying to make sure you follow along the study routine I've been telling everyone. So let's take a look at that right here. So it's one of the large vessel vasculitis, right? There's only two, Takayasu and giant cell. Giant cell is usually elderly females, unilateral headache, possible temporal artery tenderness, and jaw claudication because of the maxillary artery. May lead to irreversible blindness due to the ophthalmic artery. Right? So all these arteries are being inflamed like crazy and they're not going to work very well, and that can lead to different problems depending on what the artery is. Associated with polymyalgia rheumatica, which is what we're looking at now. So you see it tells you here, treat with high dose corticosteroids prior to temporal artery biopsy to prevent blindness. Now if we go back to where we were right now, to treat just the polymyalgia rheumatica, you can use low dose corticosteroids. Alright, so this is a little difference that you might have to pick between in your question based off of what the patient is presenting with. So if there's a chance that she's got inflammation of her ophthalmic artery, if there's a chance that you think there's also giant cell temporal arteritis in this patient, you just get her started on the high dose corticosteroids, and then you could taper it down to a lower one later on as necessary. Before I do these two questions down here, I want to look at one more thing, which is fibromyalgia. Both of these things, polymyalgia rheumatica and fibromyalgia, are actually very common presentations, mostly with young women, and by young women I mean under 40, coming into the clinic, coming into the hospital, complaining of just body pain. Okay, and then when you do their history or you ask more questions, you learn more. So fibromyalgia is seen in women who are 20 to 50. You're going to have a patient complaining about chronic, widespread musculoskeletal pain associated with tender points, stiffness, paresthesias, poor sleep, fatigue, cognitive disturbance, and all of this is really initially only treatable with regular exercise. Right? Their issue is nothing more than just the fact that their lifestyle isn't exactly suiting, their mental and physical needs. So this is going to be a female coming in complaining about how she has pain all over her body for no real reason. There was no trauma. She doesn't have any kind of disease. Her fever is not there. Right? Her temperature's fine. She just has pain all over her body, and she often finds herself unable to fall asleep quickly. She's unable to really think clearly at work, maybe, and all that. You need to start giving her an exercise regimen. Don't just tell the patient to start working out. Tell them what to do. Go for walks. That's the easiest thing. Pick a park you like and go for walks. You need to start running. Depending on the patient's fitness and age, you can give them different advice, and that is what's really going to get the fibromyalgia to go away. You can use antidepressants or neuropathic pain agents like gabapentin, but it shouldn't really be necessary, and you should wait until you see that the regular exercise isn't really working. So now let's take a look at these three questions here. The first one is UWorld. The last two are both AMBOSS. So the UWorld question up here says, a 45-year-old woman comes to the clinic with a 3-month history of persistent shoulder and back pain and easy fatigability. She has pain and stiffness in all her muscles that worsens in the morning and evening. She does not participate in any regular exercise because her pain is exacerbated with activity. Alright. She works as a computer programmer and reports difficulty concentrating on her job. Past medical history is significant for depression and gastroesophageal reflux disease, but she's not taking any medications. Soft tissue tenderness is present at several locations bilaterally, above and below the waist. What is the most likely diagnosis? And that was a patient with fibromyalgia right there. All right, so she has back pain, shoulder pain. They use this word soft tissue tenderness at locations, right? And that was what they described here too. Tender points, right? Tender points. She has various locations that are tender. She has actual muscle pain preventing her from actually working out, right? So it's kind of unfortunate that her treatment involves regular exercise. Fibromyalgia, the precise etiology is unknown, but it likely involves abnormal central processing of painful stimuli. Although exercise can temporarily exacerbate the pain, gradual incremental aerobic exercise is proven to reduce pain and improve function. So this is what I mean by telling them what to do rather than just telling your patient, hey, you need to start working out. That's not good, right? That's not good enough, because exercise is actually also, in a sense, a medication that you're prescribing. So you can't just be like, hey, here's some insulin, take it how you like. No, you have to tell them exactly how much to take, when to take it, how to take it, and how to test if it's working, right? So with exercise as a prescription, again, do the same thing with your patients. Tell them what kind of exercise to do, how much to do it, when to do it, and how it's going to show effort, right? How it's going to show effect, I mean. So gradual incremental aerobic exercise, which basically should mean, depending on the patient's age and lifestyle and physical condition, walking. Everyone can do it. You just go for long walks. It's great for people. TCAs and SNRIs modify the processing of pain signals and can also be considered in patients with more severe or refractory symptoms. Diagnosis is made in patients with chronic back pain and fatigue for more than 3 months in the absence of physical or lab findings suggestive of an inflammatory etiology or other chronic pain syndrome. So you see how, unlike polymyalgia rheumatica, fibromyalgia does not have inflammation. There's no elevated ESR, no elevated CRP, nor do they have rhabdomyolysis, so there's no elevated CK either. Everything's pretty much fine in them. They just have abnormal, weird pain. But it's not actual pain. It's not that they're really in pain, they're just feeling it, right? And there's this concept of fibro fog. They can't really focus at work. They can't study, whatever their age is based off of that, right? If it's a 21-year-old going to college, she might not be able to study very well for her finals, and that's why she's coming in today. Amboss has these 2 questions. So this one right here says, a 38-year-old woman comes to the physician because of a 3-month history of moderate abdominal pain that is unresponsive to medication. She has a history of 2 spontaneous abortions at 11 and 12 weeks gestation. Ultrasound exam of the abdomen shows normal liver parenchyma, a dilated portal vein, and splenic enlargement. Upper endoscopy shows dilated submucosal veins in the lower esophagus. Further evaluation of this patient is most likely to show which of the following findings. Okay. So this is how you think about this question. This is kind of how Amboss teaches. So they tell you that the patient's presentation of a dilated portal vein, splenic enlargement, and dilated lower esophageal submucosal veins with an ultrasound showing normal liver parenchyma all suggest portal hypertension due to portal vein thrombosis, right? Very obvious. In fact, when we did GIT, we saw a question that was directly about portal vein thrombosis, where the liver itself is fine. You're not messing up the sinusoids of the liver, so you're not going to have ascites in the patient, right? But you will have symptoms that you're seeing here, the splenic enlargement, the dilation of all these other blood vessels, right? Because the portal vein is thrombosed, there's this big clot there now, and everything's backing up. Thrombocytopenia is a common presentation in patients with an enlarged spleen because enlargement can increase splenic activity, leading to the rapid clearance of platelets from the bloodstream. Splenic enlargement and esophageal varices are seen in all forms of portal hypertension because they have collateral circulation. And you need to go back and look at that anatomy from GIT if you forgot. However, unlike post-hepatic and hepatic causes of portal hypertension, like Budd-Chiari syndrome and cirrhosis, pre-hepatic causes of portal hypertension, such as splenic or portal vein thrombosis, are usually not associated with ascites. And that's a really big deal, right? I just said it right now, too. Ascites is a giveaway for where the thrombosis is. Is it inside the liver or outside? If it's outside the liver, you will not have ascites. Repeated spontaneous miscarriages in patients with thrombophilia, as suggested here by the diagnosis of portal vein thrombosis, is suspicious of antiphospholipid syndrome, and that's what she has. Right? Remember that in antiphospholipid syndrome, you have lupus anticoagulant. If you have an anticoagulant, right, then that's problematic because the lupus anticoagulant and the anti-beta-2-glycoproteins, all of these guys kind of work together to mess things up really bad. They have prolonged PTT, so they're not actually coagulating well at all. And they can actually, because of the antibodies, they can even have a case scenario of hypercoagulability. And that's what you're seeing here, right? Portal vein thrombosis in this patient. Last question down here, this one says, 47-year-old woman comes to the physician because of body aches for the last 9 months. She also has stiffness of the shoulders and knees that is worse in the morning and tingling in the upper extremities. Examination shows marked tenderness over the posterior neck, bilateral mid-trapezius, and medial aspect of the left knee. A complete blood count and erythrocyte sedimentation rate are within reference ranges. Which of the following is the most likely diagnosis? So again, they use this concept of tender points. Remember? They tell you that fibromyalgia patients have tender points. and they told you what the tender points are for this patient. Examination shows tenderness over these points: posterior neck, bilateral mid-trapezius, medial knee, right? So those tender points are a giveaway for fibromyalgia, and you confirm the fibromyalgia by making sure there's no inflammation, no rhabdomyolysis, and you can see that CBC and ESR are normal. ESR is a sign of, ESR and CRP are both signs of inflammation. If there's no inflammation and this patient has tender points and it's a 47-year-old female that has chronic pain, that's a giveaway for fibromyalgia. And now that the psychopath is active, I'll say that we can stop right here. And we'll continue on from polymyositis and wrap up the rest of musculoskeletal pathology in the next video. But yeah, 55 minutes, that's pretty good. Thanks a lot for joining. Keep studying, keep reviewing the things I mentioned right now, from cardiovascular, the polymyalgia rheumatica, and the coagulation factors, right? These are all things that were mentioned in this section right now. These are all things we talked about in this video right now. So it's a good time to go back and review that again, because repetition and revision are really the only main ways you'll be able to master those topics and remember them forever. Alright, so thanks a lot for joining. Next video we'll continue on and finish up musculoskeletal pathology.